Hello, my name is Dr. Andreas Fontalis. I am a trauma and orthopedics resident at University College Hospital in London and a PhD candidate at University College London. I'm one of the lead authors of this JBJS article, Inflammatory Response in Robotic-Arm-Assisted Total Knee Arthroplasty versus Conventional Jig-Based and the Correlation with Early Functional Outcomes Results of a Prospective Randomized Control Trial. On behalf of my co-investigators and myself, we hope that you find this article interesting and insightful, and we also hope it will add to the body of evidence concerning outcomes following robotic arm-assisted versus conventional TKA. Now, the exact etiology of patient dissatisfaction in TKA is unclear. However, the inflammatory response precipitated by surgery may be implicated. We recently conducted and disseminated results of a randomized control trial studying the systemic inflammatory response in robotic arm-assisted versus conventional TKA. We found that robotic arm-assisted TKA was associated with a transient reduction on the 7th postoperative day and with less iatrogenic soft tissue injury and bone trauma. Conceptually, we hypothesized that it could also be associated with a reduction in local inflammation. So in the second phase of the RCT, we studied locally induced inflammation measured from the intra-articular drain fluid samples, functional outcomes, and PROMs. This was a prospective RCT encompassing 30 patients with knee osteoarthritis that were randomly allocated to robotic arm-assisted TKA or conventional TKA. We found that robotic arm-assisted TKA was associated with reduced levels of interleukin-6 at 6 and 24 hours, reduced levels of interleukin-8 at 6 hours, and no difference in levels of TNF-alpha. Pain scores in the robotic arm-assisted group were significantly lower on day 1, 2, and 7. There was no difference with regards to length of stay, number of physiotherapy sessions, or early functional outcomes. PROMs were comparable between the two groups at 2 years. However, as our primary objective was to evaluate the inflammatory response, we were underpowered for unmasking any statistically significant difference in PROMs. Now, possible explanations for the difference in inflammatory response could include the use of intramedullary guide, the metal debris from conventional cutting blocks in conventional TKA, or reflect the reduced bone and soft tissue injury with robotic technology. We hope our pilot results will fuel further research, and in our view it would be captivating to quantify the different components of inflammation by comparing different techniques. For example, utilization of navigation in TKA entails the use of pins and cutting blocks but no intramedullary rod. Hence, by comparing navigation to robotic arm assistance, we may be able to ascertain the impact of haptics. In the same vein, by comparing navigation to conventional TKA, we could be able to study the effect of registration pins versus intramedullary rod. Lastly, I would like to take advantage of this opportunity to point out that its robotic system has a unique set of design characteristics, whether it's imageless or image-based, whether it has haptically confounded boundaries or not. Hence, it would not be methodologically sound to lump them together, and each system should generate its own evidence, therefore potentially affecting the generalizability of our findings. I would like to thank you once again for your interest in our study, and we do hope you found it to be an interesting read, allowing a multi-dimensional evaluation of outcomes between the two procedures, and hopefully a useful addition to the body of evidence to identify the optimal TKA procedure that reduces the soft tissue and bone injury and confers better functional and patient-reported outcomes. Thank you very much.